We're going to move topics now and talk more towards some exciting findings on treatment that are going to be presented. Our first presentation in these series will be made by Daniel Cohen, and he's going to speak to us about interferon-free 3 DAA plus ribavirin regimen in hepatitis C genotype 1 infected patients on methadone or buprenorphine.
Well, thank you, Dr. Klein, Dr. Peters, ladies and gentlemen. On behalf of my co-authors, I'm pleased to present an interferon-free 3 direct-acting antiviral regimen plus ribavirin in hepatitis C genotype 1 infected patients who are on methadone or buprenorphine. These are the disclosures of the authors, and please note that I am an AbbVie employee. By way of background, it's no surprise to anybody here that people with a history of injection drug use have a high prevalence of hepatitis C infection. However, only a minority initiate treatment, in large part due to the toxicity of interferon-based therapies. And of those who do start treatment, only a fraction complete therapy. The new interferon-free treatment regimens of direct-acting antivirals, which are currently in development, are associated with significantly less toxicity, and they may improve treatment uptake and completion rates among patients with a history of injection drug use, including those on opioid replacement therapy. AbbVie has a 3 DAA regimen in development currently. The regimen includes a co-formulated tablet which contains ABT450, an HCV protease inhibitor, a 100 milligram daily dose of ritonavir as a pharmacokinetic enhancer for ABT450. That ritonavir boosting is I'm sure, not a novel concept to this audience, and ombidisvir, a potent NS5A inhibitor. This co-formulated tablet is dosed with dasabuvir, a non-nucleoside inhibitor of the viral polymerase, which is dosed twice daily. This 3 DAA regimen has currently been studied in approximately 2,700 patients in the development program, and the results of the phase 3 studies of this regimen have recently been published. A 12-week course of the 3 DAAs with ribavirin achieved sustained virologic response rates of 96% in genotype 1 infected patients without cirrhosis who were either treatment naive or treatment experienced. A 12-week course of the 3 DAA regimen without ribavirin in patients with genotype 1b infection achieved sustained virologic response rates of 99% and greater in patients without cirrhosis. And in a dedicated phase 3 trial of patients with compensated cirrhosis, 12 or 24 weeks of the 3 DAA regimen with ribavirin achieved SVR rates of 92 to 96% in genotype 1 infected patients. The regimen was well tolerated across the phase 3 program with overall discontinuation rates of 2% or less in each of the phase 3 trials. The current study, M14-103, is a phase 2 single-arm open-label study which was conducted in the United States, evaluating the safety and efficacy of this 3 DAA regimen with ribavirin when given for 12 weeks to genotype 1 infected non-cirrhotic patients who are on stable opioid replacement therapy. Treatment response, which was defined as an HCV RNA level less than the lower limit of quantification, 25 international units per ml, was assessed at the end of treatment as well as at post-treatment weeks 4, 12, and 24. And safety was assessed throughout the course of the study. These are the eligibility criteria for patients in the study. They were 18 to 70 years of age with a BMI less than 38 kilograms per meter squared. They had chronic genotype 1 infection, but no cirrhosis. Patients could be either treatment naive or previously treated with PEG interferon and ribavirin. They had to be on a stable opioid replacement therapy of either methadone or buprenorphine for at least 6 months prior to study start. And this is the sole HIV negative presentation in this session, since patients were excluded if they were co-infected with either HIV or hepatitis B, or if there were any other causes of liver disease present besides hepatitis C. This is the simple study design. All patients who were enrolled in the study were started in a single treatment arm and received the 3 DAA regimen with ribavirin for a total of 12 weeks. The 3 DAA regimen comprising the co-formulated tablet once daily and dasabuvir twice daily, in addition to ribavirin, which was dosed according to body weight at 1,000 to 1,200 milligrams daily, divided into 2 doses per day. These are the baseline characteristics of the patients enrolled in the study. They were predominantly Caucasian. 2/3 of the patients were male. The baseline HCV RNA level was about 6.6 log IU per ml. The favorable IL-28B CC genotype was present in approximately 1/3 of the patients. Baseline fibrosis stage was predominantly mild or moderate fibrosis. Remember, again, cirrhotics were excluded. 2/3 of the patients in the study were infected with genotype 1A, consistent with the epidemiology in the United States. All but 2 of the patients were treatment naive, consistent with what I said at the beginning about a low rate of treatment in this population. And the patients were divided evenly between those who were on methadone maintenance and those who were on buprenorphine maintenance. So here then are the efficacy results. Of the 38 patients enrolled in the study, 37 patients achieved viral suppression at the end of treatment and maintained viral suppression through all the post-treatment time points shown for an SVR rate of 97.4%. There were no virologic breakthroughs and no relapses in this study. The one patient who failed to achieve SVR discontinued study participation prematurely after his week 2 study visit due to a serious adverse event. This patient suffered a stroke after his week 2 study visit and was found on workup to have a mass in the upper lobe of the right lung, which was subsequently diagnosed as a high-grade sarcoma. This unfortunate series of events was considered unrelated to study participation, unrelated to study drug, but the patient did discontinue study participation at that point. Turning now to the safety of the regimen, the majority of patients in this study did experience at least one adverse event. However, these were predominantly mild or moderate adverse events. 2 patients had serious adverse events reported. One, the patient I just told you about who discontinued, and the second, a patient who shortly after completing therapy was diagnosed with acute myeloid leukemia. So we had quite a run of bad luck in this study, but that adverse event was also considered unrelated to study participation, and the patient did continue in post-treatment follow-up and did achieve a sustained virologic response. Of note, none of the patients in the study required any change in their opioid replacement therapy dosage during treatment or after treatment was completed. These are the most frequent adverse events seen in this study, and the most common were nausea, fatigue, headache, insomnia, and rash. Again, I will stress that most of these adverse events were mild in severity, and these are fairly typical adverse events for a regimen containing ribavirin. Laboratory abnormalities of note are shown here. Regimens containing ABT-450 have been associated with transient elevations of indirect bilirubin due to inhibition of bilirubin transport proteins as well as ribavirin-induced hemolysis. And in this study, 1 patient experienced a grade 3 elevation of total bilirubin. The highest bilirubin level this patient achieved was about 5.8 milligrams per deciliter. This was predominantly indirect bilirubin, resolved with continued dosing, and was not associated with any findings consistent with hepatotoxicity. 8 of the patients in this study experienced hemoglobin reductions below 10 grams per deciliter, presumably due to ribavirin. 2 of those patients had single values less than 8 grams per deciliter, and 7 of those 8 patients were managed with ribavirin dose reduction. And it's noteworthy that all 7 of those patients who reduced the ribavirin dose did achieve SVR. The 8th patient was the one who discontinued prematurely. So as I mentioned at the outset, the poor tolerability of interferon-based therapy has been a significant barrier to treatment uptake and completion among people with a history of injection drug use, including those on opioid replacement therapy. However, patients on stable opioid replacement therapy may be ideal candidates for a short course all-oral treatment regimen for hepatitis C, since they are already linked into healthcare and presumably have demonstrated some ability to comply with an oral treatment regimen. Also worth noting, this study was completed prior to the results from our phase 3 PEARL studies, which demonstrated that in genotype 1B infected patients, ribavirin is not necessary to achieve high sustained virologic response rates with this regimen. Therefore, all the patients in this study who had genotype 1B infection did receive ribavirin, but they might conceivably have been treated without ribavirin with equal success. So in conclusion then, ladies and gentlemen. The 3 DAA regimen with ribavirin achieved a sustained virologic response rate of 97.4% in this population of 38 genotype 1 infected patients on stable opioid replacement therapy. This response rate is comparable to the rate that had been seen previously in the phase 3 program in genotype 1 infected patients who are either treatment naive or treatment experienced. No viral breakthroughs or relapses were seen in this study. The treatment regimen was well tolerated in this study, as evidenced by the fact that no subject discontinued due to study drug-related adverse events, and most of the adverse events experienced in the study were mild in severity. Of particular note, drug interactions, which may be a concern in a regimen like this, did not impact either the success of the HCV treatment or the opioid maintenance for these patients. We conclude then that a 12-week, highly efficacious, well-tolerated, all-oral regimen may be an attractive treatment option for HCV-infected patients who are receiving opioid replacement therapy. And on behalf of my co-authors, I would like to acknowledge the patients who participated in the study, the study coordinators at the sites who conducted the study, and the study team at AbbVie. And thank you for your attention. I'll be happy to take any questions.
Any questions? I wondered whether there were any guidelines in the protocol with respect to dose adjustments for either buprenorphine or methadone. Some of the side effects that people experience, while they could be related to ribavirin or the other part, ritonavir part of the regimen, were nausea, fatigue. It could have been early symptoms of opioid withdrawal, for example.
Yeah, that's an important question, and we were, of course, scrutinizing the safety data set very closely for any evidence of either over or under narcotization in the study. We had previously done drug interaction studies with methadone and buprenorphine and found no impact on methadone or buprenorphine pharmacokinetics or pharmacodynamics. We had left it to the discretion of the investigators whether the methadone or buprenorphine dosage needed to be adjusted.
So we often don't include these patients in studies in ongoing clinical trials, but also in clinical practice. So were these highly selected patients or not, and how did you evaluate adherence?
Well, given the fact that we were relying on these 38 patients to determine the success or failure of this regimen, I think it's fair to say these were fairly well-selected patients. So perhaps not the typical patient with a history of injection drug use who might be seen in the clinic. Adherence was monitored in this study by pill counts. Patients were to bring their pills in at every study visit. And in fact, they did a remarkably good job of coming in for all of their study visits, again, attesting to the fact that either patients on opioid replacement therapy are very adherent, or this was a particularly adherent subset.
And I guess one final question. Most of the participants in the study had very low levels of fibrosis. It looked like the majority were F0 to F1. Would you anticipate any change in the pharmacokinetics or dynamics of these drugs with more advanced cirrhosis?
Yeah, that's obviously also an important question. As liver fibrosis advances, it can be harder and harder to predict of course, the pharmacodynamics of co-administered medications. We have studied the pharmacokinetics of our DAA regimen in patients with mild, moderate, and severe liver impairment, but the interaction with methadone and buprenorphine may be unpredictable in patients with more advanced disease. So it's at this point an unanswered question.
So
there's a question back here.
Oh, sorry.
Sorry. Could you comment on the frequency of malignancy across your program and what was seen amongst both HIV positive and HIV negative individuals? Because obviously in a clinical trial program you report relationship with study drug by what's been seen in the information sheets in previous work rather than what's been observed prospectively in studies. So it would be nice to know about the malignancy rates that you've seen.
Yeah, we of course were disappointed to have 2 malignancies in this small study. Across the 2,700 patients who have previously been treated with this regimen, we did not see a signal consistent with a malignant predisposition with this regimen. I can't quote you the exact incidence rate, but there was no evidence of any malignancy occurring as a result of exposure to this treatment regimen.
Are you suggesting at present that patients with cirrhosis not be, if they're on buprenorphine or methadone, not be treated with your regimen, or you don't just know?
Well, it's obvious that we haven't studied that population. Right. I think based on the data we've seen from our phase 3 program, for patients with cirrhosis who have compensated liver disease, it is likely that treatment with this regimen will be as successful or nearly as successful as in patients without cirrhosis. And I think it's a reasonable extrapolation that patients with compensated liver disease who are on opioid replacement therapy may be candidates for this treatment. I don't think we can extrapolate at this point to patients with more advanced liver disease.
Can't see anyone out there.
I think we can.
Thank you very much.
Thank you.